Good evening, everybody. My name is Jacob. I am an IPC nurse from Cameroon, and I'm also a member of Infection Control Africa Network. This afternoon, I will be sharing with you the findings of a project that was implemented in Cameroon on introducing alcohol-based hand rub at the point of care. This is the introduction this is the outline we are going to use. We will begin with introduction, then we will go to methodology, we will look at the results, lesson learned, and then conclusion. Healthcare-associated infection and antimicrobial resistance are major threats to patient safety worldwide. And the situation is even more significant in developing countries because IPC practices are relatively poor. Although hand hygiene has been proven to be a simple but very effective intervention to prevent the transmission of infections, compliance remains significantly low. And the situation is even worse in a resource-limited setting due to absence of resources and infrastructure. The aim of this study was to evaluate the implementation of the wall-mounted alcohol-based hand rub at the point of care on the hand hygiene compliance amongst healthcare workers. Methodology. We started by training hand hygiene observers for a period of 5 days. And during this training, they received information about hand hygiene, about 5 moments, about the WHO hand hygiene observation tool, and then they also practiced how to observe hand hygiene and to enter data into this tool. Then we also taught them how to collect data and how to enter the data. And then lastly, they also did some practical session under observation as well as independently. The study was implemented in Banso Baptist Hospital, which is a tertiary referral hospital located in the northwest region of Cameroon. We selected 2 units, the maternity and the surgical ward, and the choice of the unit were based on the volume of activities as well as the risk of infection associated to care in these 2 units. Then we also limited to 2 units because the funds that we have were also limited and the study period was also very brief. The design was the 3-phase study. The first phase was baseline, lasting 12 weeks. The next one was the implementation phase, still 12 weeks. And then the third one, was the post-implementation phase, lasting 12 weeks. That is a total of 36 weeks. I am going to explain what was happening at each stage of the study. During the baseline, we were simply observing hand hygiene practices in the unit without introducing any intervention. And then we were also collecting data on the volume of alcohol-based hand rub used per week per unit. We did not do any training. We did not introduce any hand rub at the point of care. And then we were also not giving feedback. During the second stage, we started by organizing a 2-day workshop for all the staff. And during this workshop, we taught the staff the importance of hand hygiene, how to perform hand hygiene, specifically how to apply alcohol-based hand rub. And then we also taught them on the 5 moments. Then after that, now we introduced the wall-mounted alcohol-based hand rub at the point of care, that is by the bedside. And then now we started observing hand hygiene practices as we did for phase 1. And then at this time now, we started giving feedback to the staff after every session. And then we also continued to collect data on the volume of alcohol-based hand rub used per week. And then we also identify hand hygiene champions, that is those who were excelling in hand hygiene performance, and then we recognize them publicly as a way of motivating the rest of the staff to copy from their example. Then during the post-implementation phase, the objective here was to evaluate if the improvement that were observed during the implementation phase will be sustained during this period. It also lasted 12 weeks. And at this time, all the activities that were implemented in the phase 2 were replicated except for training. So we did not do any training at this stage. Then data was collected using WHO hand hygiene observation tool by observation. Then ethical approval were obtained from the different institutions, as well as administrative approval from the Director of CBC Health Services. There was no need for patient consent because we did not collect any patient data. This slide is about the results. We had 417 hand hygiene observation sessions with a total of 5,217 hand hygiene opportunities, 60% of which were for surgical ward. The volume of hand hygiene opportunities in surgical ward directly corresponds to the volume of activities and the number of staff in that unit. This slide talks about the average hand hygiene compliance per study phase. As you can see, hand hygiene compliance increased steadily from baseline to implementation, as well as to post-implementation. We are going to analyze more detailedly in subsequent slides. This slide is about comparison of hand hygiene compliance in both study unit, maternity, and the surgical ward. Here you will notice that hand hygiene compliance improved from baseline to implementation and to post-implementation in both units, both the maternity and the surgical ward. Here, this slide compares hand hygiene compliance in the different units and also according to professional categories. On this slide, you will see that hand hygiene compliance improved in all the units as well as for all the professional categories, including nurses and midwives and doctors. This slide talks about data analysis of the hand hygiene compliance. Here, hand hygiene compliance in the maternity unit was significantly higher compared with the surgical unit. However, when analyzed per study period, the significant difference was observed only at the baseline. On the surgical unit, significant increase in hand hygiene compliance in the implementation stage compared with the baseline was observed, and a further significant increase was also observed during the post-implementation stage. This slide continues to compare hand hygiene compliance in the different units. On the maternity unit, compliance during the implementation stage improved significantly compared to baseline and the post-implementation stage, but no significant difference was found between implementation and the post-implementation stages. When a change in hand hygiene compliance between the study stages was analyzed per professional group, a significant increase in compliance was observed among all professional groups. This slide is about the volume of alcohol-based hand rub used per week throughout the different study weeks from week 1 to week 36. Here you will also see that there was a significant increase. However, there were fluctuations, and these fluctuations were caused by different factors. First, sometimes when there were students in the unit, the volume of hand rub used that week will increase due to the number of staff. The number of staff in the unit will significantly increase. This slide continues to analyze the volume of hand rub use. Here you will see that the volume of hand rub use increased from baseline to implementation and post-implementation in surgical ward and in the maternity, as well as both units combined. This slide continues to analyze the volume of hand rub use per week. As shown in table 3 above, both units, the median weekly alcohol-based hand rub usage increased significantly during the implementation stage in comparison to the baseline. Furthermore, in both units, the median weekly alcohol-based hand rub usage increased further during the post-implementation stage. However, this increase was statistically significant only when compared with baseline, but not with the implementation stage. This slide is about lesson learned. Our study has shown that the implementation of wall-mounted alcohol-based hand rub at the point of care, supported by training, monitoring and feedback, and designation of hand hygiene champions, resulted in a significant improvement in hand hygiene compliance. This improvement was sustained in the post-implementation stage. We observed a significant increase in the volume of alcohol-based hand rub use per week in all the participating units. This slide is about conclusion. Our study demonstrated that appropriately adapted interventions for the improvement of hand hygiene are feasible and can lead to substantial and sustained improvement in hand hygiene compliance. Regular monitoring of hand hygiene practices and feedback provision, as well as development of patient safety environment by appointing champions and the provision of education were all likely to contribute to the successful implementation of the wall-mounted alcohol-based hand rub at the point of care, as well as improvement in hand hygiene compliance. However, further studies are needed to evaluate the sustainability of the intervention in the long term, as well as to demonstrate its impact on healthcare-associated infections, as well as antimicrobial resistance. This study was published in American Journal of Infection Control in 2003. Thank you for your kind attention.